Hi everyone and welcome to the RACGP National Webinar Series. I'd like to begin by acknowledging the traditional owners of the lands on which this meeting is being facilitated and being accessed by the various participants and pay my respects to the elders past, present and future of these lands. Before we start with the webinar, I'd like to run through some features to make sure you can interact throughout the webinar. So we should be able to show a slide now showing where is my control panel. So you should be able to see the control panel like the image on the right of your screen. If you can only see a few icons like the image on the left, please click on the red arrow to be able to open the rest of the control panel. And the control panel provides you with the tools to select your audio options and is also a place to ask questions during the webinar. You are on mute, but you can adjust your audio. You can send questions throughout the webinar and we've allowed time at the end to answer those. We won't be able to take questions during the content of the webinar. We may also not have time to get to all questions, but we'll hope to answer as many as possible. This session does include a case study, but due to the number of people involved and the amount of time we have allowed, we're not actually expecting you to answer some of the rhetorical questions in the case studies. Now, to test this feature, please click where it says questions to enter a question for the staff and type where you are located today. Okay, we've got Canberra, Adelaide, Melbourne, Gold Coast, Tamworth, Wellington Point, Cooktown. This is fantastic. We've got people from all over the place. Casterton, Bribie, Darwin. Excellent. I think we know we can use that function now. And we'll also move on to the poll test slide. So we'll be conducting some polls throughout the seminar, and I'm just going to launch the first one now. And we would like you to select a colour from below. Okay. So over 50% voted. Okay, it's about 75% of you have voted now. So we'll close that poll now, and blue appears to be the clear winner with 42%, followed by 23% on green. I don't know what that says about our participants. Okay, great. So just a reminder, if you've entered your RACGP number while registering, you'll be sent a survey to complete in order to receive your 2 Category 2 points. And now we're all familiar with the way that this webinar is going to work, we'll get started. So I'd like to mention that this webinar is proudly supported by ASHM, which is the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine. Tonight's webinar is on hepatitis C, cure chronic disease in general practice. GPs can now prescribe new oral direct-acting antivirals for hepatitis C. This offers cure rates greater than 95% with 8 to 12 weeks of well-tolerated treatment. This 1.5-hour webinar will present a practical step-by-step guide to the screening, management and treatment of hepatitis C. The session will outline the key questions for hepatitis C testing, diagnosis and assessment, and how and when to treat in general practice. I'd like to introduce tonight's presenter, Dr. David Iser. Dr. Iser is a gastroenterologist and hepatologist with an expertise in the treatment of viral hepatitis. He treats people with a range of conditions at both St Vincent's and the Alfred Hospitals in Melbourne. His interest includes treating people in special populations, such as people with HIV co-infection and people in prisons, and upskilling GPs towards the elimination of viral hepatitis. Thank you very much, David, and I'll let you take over.
Fantastic. Thank you very much, Amy, and thanks to the organisers of tonight's webinar, sharing the excitement of the treatment of hepatitis C, and with particular focus on broadening treatment to GPs who are attending the webinar. And a particular welcome to our attendees from all over Australia, and I did actually see that we have an international attendee in Samoa, so that's fantastic, and welcome to tonight's presentation. So here are my disclosures. It's been a sort of very exciting time over the last couple of years in the treatment of hepatitis C, and there have been a lot of new changes, and in sort of implementing these changes, we've given a lot of presentations over the last few years, but there is still plenty of work to be done, as you'll see throughout the presentation. So what we hope that you'll get out of this presentation is that by the end, you'll be able to identify who is appropriate for testing for hepatitis C. You'll know the tests to request, and you'll know how to interpret the results. You'll know how to assess for liver fibrosis and how to assess your patients for important comorbidities that might influence your treatment decisions. And you'll be able to have some confidence in deciding which patients you can comfortably treat and which patients still require referral for specialist management. But as you'll see, the vast majority of people living with hepatitis C in Australia who need treatment are actually suitable for treatment in primary care, that is, treatment in your practices. So when the direct-acting antivirals became available on the PBS on the 1st of March in 2016, we estimated that there were about 230,000 Australians living with chronic hepatitis C. And as you can see, by the end of 2017, so just under 2 years later, that number had fallen from 230,000 to only 180,000. Since the end of 2017, we've treated probably another 25 to 30,000, maybe even more. So we estimate that now we might be looking at about 150,000 Australians living with chronic hepatitis C. But it's important to realise that still 1 in 5 of those 150,000, so up to 30,000 Australians, may still be unaware of their diagnosis of hepatitis C. And we know this from various sero-surveys that are done over the years, particularly by the group at the Kirby, headed by Greg Dorr and Gail Matthews and Jason Grebley. So we're reasonably confident of these data. What you can see from this figure over on the overlying the map of Australia is that around half of those people living with hepatitis C have genotype 1, and about a third have genotype 3, and the remainder is made up of other genotypes. We'll talk a little bit in more detail about genotypes later on, but at the moment we're still required to test hepatitis C genotype because it's a requirement by the PBS. It's one of those bits of information they ask as you're writing the prescription on the 1-800 number. So how do we find that undiagnosed 20%? So you're probably aware, because it's had a fair amount of media over the last couple of years, that in late 2015, the government agreed to fund these direct-acting antivirals, or DAAs. And this was a very exciting announcement because we were one of the few countries in the world at that time, and even now, to allow anyone with chronic hepatitis C to be treated with government subsidisation. Some other countries restrict it on the basis of disease stage, so they may restrict it to people just with cirrhosis or advanced disease. But in Australia, anyone with the virus is eligible for treatment. And there was a lot of media attention given to that initial estimated cost price. So if you look on the side of the bottle, or if you look on the PBS website, you can calculate a cost price up to and around $100,000 if you add up those list prices. But in fact, we think that the actual cost that the government's paying is only around $10,000 per treatment course. So that is one of the lowest prices in the world, and it's definitely cost effective particularly when you consider that treatment of hepatitis C is treatment for cure. And we'll talk a little bit about the concept of cure later on. So where do GPs fit in our role in the hepatitis C response? Well, GPs are vital in screening for hepatitis C, vital in managing people living with hepatitis C and providing treatment, vital in assessing and managing comorbidities such as ongoing drug use, mental health conditions and other chronic diseases. And I'm sure you're all familiar with managing people living with chronic diseases. Australia is very fortunate, although it was not just good fortune, it was also good planning, in that we did do a fair bit of education of general practitioners leading up to this March the 1st, 2016. We had tried to include general practitioners in the treatment of hepatitis C prior to the arrival of DAAs, and you can see that from this chart, when DAAs became available in March, GPs made up just a small proportion of the prescriptions written. But as that time has elapsed, you can see that GPs are making up a much more significant proportion of those prescribing hepatitis C treatments. And what we've seen in other countries where primary care is not so involved in treatment is that treatment numbers have fallen dramatically once all of those people who are sitting in our waiting rooms on our databases waiting for treatment, once the specialists had treated all of those patients, there was no one left to treat. And overseas, they don't really have the infrastructure to go and find all these people who are still living with chronic hepatitis C. But in Australia, we have a growing body of experienced GPs or interested GPs and GPs with expertise who are treating people living with hepatitis C. So that's really important. So let's talk about identifying who might be at risk. And there's lots of ways of approaching this. In America, the CDC a few years ago suggested cohort screening, where they just suggested anyone born in the baby boomer generation from 1945 to 65 should be tested. What they then found was, in fact, other birth cohorts had a similarly high rate to baby boomers. So you could almost make the argument that anyone should be tested. And certainly we have a very low threshold for testing someone with hepatitis C. But if we were to target people at highest risk of hepatitis C, we would target women who are pregnant as a part of their antenatal screening. We would target the partners of people who are known to have hepatitis C. We would target the children of mothers known to have hepatitis C, although not many people would necessarily be aware of their mother's hepatitis C status, so that is a somewhat problematic definition. We could include it as part of any baseline check. We could include it as part of family planning or prior to travel. We should certainly consider testing for hepatitis C in anyone with abnormal liver function tests, particularly the ALT. We should certainly consider it in anyone who's experiencing fatigue or jaundice. And anyone who's testing positive for one of the other bloodborne viruses, hepatitis B or HIV, should certainly be tested for hepatitis C. I always try and think of the idea of testing positive for one bloodborne virus should trigger testing for all bloodborne viruses. So to sort of frame our discussion, we've included the case of Tim, who could represent almost anyone in your practice. So in this case, Tim is a 56-year-old office worker. He's new to your practice, having moved into the area. He's describing fatigue, but is otherwise well. He takes no regular medications, drinks minimal alcohol, and during his history, he reveals that he briefly injected drugs in the 1980s. Now, I must say, having not written this case myself, I think that's a pretty odd thing to offer in your first visit to a new GP in a new area. Not many people offer that they once injected drugs in the 1980s, but this may have been on Tim's mind. Some people injected drugs in the 1980s and don't even remember it. So I wouldn't rely on that as being a trigger necessarily to test for hepatitis C. So the rhetorical question, what do you do next? Well, this is a webinar on hepatitis C, so let's test Tim for hepatitis C. So how are we going to do that? So we really should be thinking about testing, as I said before, anyone who's ever injected drugs, but the caveat being that often people won't offer that, particularly in their first consultation. They may not remember it. I've certainly seen patients who've presented at the blood bank, tested positive for hepatitis C, they've been in their late 50s or 60s, then when the positive test comes back, they remember, oh yes, I went to that party in the 70s and injected drugs. So it's not necessarily a reliable piece of history to take, but anyone who has injected drugs should be tested. Tattoos or body piercings, particularly before the early 1990s, anyone who identifies as Aboriginal or Torres Strait Islander, or anyone born overseas in a high prevalence area. And you can see there we've included Africa, particularly Egypt, where in some cohorts the rate or the prevalence is as high as 20%. The subcontinent, including India and Pakistan, Mediterranean and Eastern Europe, the rest of Africa, and really anywhere in Asia, even the Pacific. We haven't included it in this presentation, but we should remember that every year there are still 1.5 million new infections of hepatitis C. So hepatitis C is still being spread, particularly in other parts of the world. We should also test anyone who's had sex with a hepatitis C positive person. Again, the caveat is that not many people are aware of their hepatitis C status or disclose it when having unprotected sex. But particularly men having sex with men and or men who are known to be co-infected with HIV and hepatitis C. We have probably treated most people who received blood transfusions before 1990, but not all. I've talked about the caveats of knowing your mother's hepatitis C status, talked about C1 blood-borne virus test for all. I've mentioned anyone with an abnormal ALT, and remember that our normal ranges are not true normals. So the true normal is an upper limit of 30 for men and 19 for women. So you may even see someone who's complaining of fatigue, whose ALT is 35, that fits in with your laboratory's normal range, but it's actually not a true normal. And certainly anyone after a needle stick injury should have testing for hepatitis C. So that brings us to polling question 1. So polling question 1, which of the following is not a mode of transmission for hepatitis C? And our options are sharing personal hygiene, experiencing traumatic unprotected sex, having unsterile tattoos or body piercing, sharing injecting drug use equipment, or sharing cutlery or cups. So you should be able to poll now, and you are polling, so that's very good. Up to about 70%, that might do. So let's see how we went. That's right. So sharing cutlery and cups is not a way of transmitting hepatitis C. Hepatitis C is basically a blood-borne virus. So you really need to share blood to contract hepatitis C. Having said that, hepatitis C is in semen. So if you're engaged in traumatic sex where there's mucosal breaks, it can get into the bloodstream, and that's how we think hepatitis C is transmitted through sex. So very good. I must say my my sort of adherence to inquiry about hepatitis C transmission risks has declined as hepatitis C treatment has become easier. I'm interested in treating hepatitis C and then preventing reinfection, and that will generally be via unprotected traumatic sex or via injecting drug use. I'm interested in when someone may have acquired hepatitis C, but it should also be remembered that somewhere between 15 and 20% of people with a diagnosis of hepatitis C actually don't report any known risk factors. So sometimes we can sort of wind ourselves up in knots thinking about how someone may have acquired hepatitis C, but the more relevant point is they have hepatitis C and can be treated and cured. This is a busy slide, and we've talked about most of the important points on the slide. Maybe something we haven't mentioned is that mother-to-child transmission is uncommon but not impossible. So we think the mother-to-child transmission risk is somewhere between 3 and 5%. Now that sounds low, but I have said that figure to a pregnant woman and watched her burst into tears, because 3 and 5% to someone with hepatitis C who's pregnant can sound catastrophically high. So it's a different number depending on who you are, I guess. The risk of heterosexual transmission in stable couples is pretty low. It's estimated at about sort of 1% per year in a landmark Italian study from several years ago. Whereas in men having sex with men, it's much higher. Men having sex with men where the men have HIV as well, it's even higher, up to about 10 to 15%. In the presence of other STIs, it's higher. So syphilis with a mucosal lesion can dramatically increase the risk of transmission. Household transmission's pretty uncommon. We've come across transmissions through sharing of razors, toothbrushes theoretically, but razors certainly. But sort of normal body contact, hugging and kissing, cutlery, crockery, that's not a risk. Breastfeeding is, it's difficult to get data around breastfeeding, but it's not recommended if you can see blood, if there are cracked nipples, but otherwise it should be okay. So back to Tim. So he declared a history of having injected drugs, so we should definitely test him for hepatitis C. So what do we request? So testing and diagnosis of hepatitis C. So we have a polling question here again, and the question is, which tests would you order? So would you request antibody and genotype? Would you request antibody and hepatitis C RNA if the antibody is positive? Would you just request genotype? Would you just request antibody? Or would you just request RNA? So this one requires a little bit more thought, and I can see you're giving it a little bit more thought, which is great. So we're up to about almost 2/3. So we might close it there and talk about the results. Yeah, so most of you got it exactly right, which is you request an antibody, the hepatitis C antibody, and then you request the hepatitis C PCR if the antibody is positive. And you can actually do that with one bleed. If you request hepatitis C antibody and then put in brackets, if positive, please do PCR and genotype. That way, when the person is undergoing the blood test, the venipuncturalist will take 2 tubes, one for the serology, the antibody, and one for PCR and genotype. And the person won't have to come back for a rebleed. The laboratory will do it all for you. So that is something you can do as GPs, and certainly saves an extra bleed. If you just asked for PCR, they would probably refuse it because they will only do it if the antibody is positive. So often this remains confusing, and it's something you probably have to read or hear a few times before it sticks. But think about the antibody as just a signpost that the virus leaves behind when it's in the body. It's basically saying, I was here. It doesn't tell you whether or not it's still here. So to decide whether or not the virus is still there, you need to test for the actual virus, which is the RNA by PCR. And we've talked about the people in whom hepatitis C antibody should be tested. So Tim's antibody test, not surprisingly, is positive. So what does this mean? That means he once upon a time had the virus. It doesn't tell us whether he still has it, but as I'm sure you can guess, that this being a webinar on hepatitis C, he will still have it. About 45% of young women will actually spontaneously clear hepatitis C. About 15% of older men with HIV will spontaneously clear hepatitis C. And anyone else is somewhere between that 15% and that 45%. So spontaneous clearance without treatment of hepatitis C certainly occurs, and that's why we need to do the hepatitis C RNA by PCR rather than just treat everyone. Overall, the spontaneous clearance rate is about 25%. So antibody positive and RNA positive, that means that someone still has hepatitis C and qualifies for treatment. If the antibody is positive and the RNA is negative, that means they've had spontaneous clearance. If the antibody is negative, that means they've never been infected with hepatitis C. The caveat is that you could have someone who infected themselves with hepatitis C 12 weeks ago, remains antibody negative, but their liver tests are all over the place. And if you asked for a hepatitis C PCR, they would be positive. So that's a special setting of acute hepatitis C, just worth having in the back of your mind. But basically, start with the antibody, also request the RNA, and then you'll be able to interpret the results. So if we're suspecting hepatitis C, we might also like to do some other blood tests. So that would include full blood examination, liver function tests, urea and electrolytes for renal function, clotting as probably an optional extra, C1 bloodborne virus test for them all, and we've included hepatitis A as a hepatitis virus as well. And then pregnancy tests for women of childbearing age. If we're considering treating someone for hepatitis C, we want to make sure that a woman is not pregnant first. So just a brief slide on hepatitis B serology. Now this is an area that I found as a student I used to have to come back to every 6 months, and every 6 months I looked at this slide and it was as if I was learning it for the first time. And I suspect there are others in the audience of several hundred who are in a similar position. But basically with chronic hepatitis B, you need to ask for 3 tests in order to work out what someone's hepatitis B status is. So you ask for a surface antigen, and that tells you whether or not they have chronic hepatitis B. So surface antigen positive equals chronic hepatitis B. Someone who has a positive surface antigen will always have a positive core antibody. Those two will go together and it equals chronic hepatitis B, and you then go on and assess for chronic hepatitis B, which is the topic of a different education evening. Their surface antibody will be negative. Somebody who's negative for all 3 tests, they are hepatitis B susceptible and should be vaccinated for hepatitis B. Someone who has positive anti-hepatitis B core antibody and anti-hepatitis B surface antibody is immune to hepatitis B through prior infection and subsequent clearance. So they don't need any further testing or any further vaccination. They are immune. If they were ever exposed to hepatitis B again, they would not get acute hepatitis B. Isolated positivity to core is a complicated scenario and probably not worth going into too much detail, but you could consider consulting a specialist. There are a variety of scenarios that could be represented here. The most common scenario is that they will have a positive surface antibody. So that's immunity to chronic hepatitis B, and that's been achieved by vaccination. So sometimes it helps to just try and derive that table yourself by first principles in about a week and see if it sticks. And if it doesn't, go back and try and make sense of it all, beginning with the surface antigen, meaning chronic hepatitis B. The relevance in a talk on or a seminar on hepatitis C is that if someone's got hepatitis B, C dual infection, that is probably still a reason to refer to a specialist. We have also seen rarely reactivations of surface antigen negative chronic hepatitis B with positive core after the hepatitis C has been successfully cured. It's rare, but it has happened, and so that's really the relevance of this little minute or two on chronic hepatitis B. So Tim's results. So you can see with his FBE that probably the most important result here is that he has a normal platelet count of 270. Not just normal, but middle of the normal range, so between 150 and 450. We often worry about people with low normal platelet counts of sort of 160, particularly if they've been declining over the past few years, because that may actually predict the development of portal hypertension and the presence of undiagnosed cirrhosis. Tim also has normal renal function, which is important because some of our medications are cleared by the kidneys. Tim has returned a pretty reassuring set of liver function tests. You can see that his albumin's at the lower end of normal range at 36, bilirubin normal at 16, just mildly raised ALT and AST of 52 and 46 respectively, slightly raised GGT, which could be from all sorts of causes, hepatitis C one of them, but maybe a little bit of fatty liver disease or a little bit of alcohol, although I think Tim didn't drink much. ALP is normal in probably most laboratories. You'll be far more expert with his lipids, but that triglyceride looks a little bit high, but he's got enough HDL and his fasting cholesterol is within the normal range for most laboratories, or it's probably below the threshold for treatment. But there's the important one, his hepatitis C RNA is positive. So without knowing anything more about Tim, he qualifies for treatment. That's all you need for treating hepatitis C in Australia, is a positive hepatitis C RNA. So importantly here is Tim is immune to hepatitis B through prior vaccination, he's negative for HIV, and he's also immune to hepatitis A, possibly through his previous combined hepatitis A-B vaccination, or maybe through previous subclinical infection. So what else should we consider? Good question. Let's assess Tim further for treatment, but so far from what we know about Tim, there's actually not that much else that we need to assess him for. We're still required, as I mentioned earlier, to do a hepatitis C genotype. We've put viral load there. It's not a requirement on the PBS, and it's becoming less important, but historically we've always measured viral loads in any bloodborne virus, BC, HIV, so it's still there, although as you'll see later on, it's of less importance. We need to use those results that we've got already, plus our clinical history taking and examination, to decide whether or not Tim has cirrhosis and make an assessment of his liver disease stage. And we've already taken a bit of a history from Tim in terms of comorbidities and alcohol consumption, but we will do this in more detail. So we'll go to the second point initially. So just talking about the staging of liver disease. So as you probably recall, liver disease can be staged from mild fibrosis, or normal liver, through to mild fibrosis, moderate fibrosis, severe or advanced fibrosis, through to cirrhosis. And what that's really referring to is the degree of scar tissue or collagen, outlined there in blue or blue on this slide here, within the liver parenchyma, within the liver tissue. Cirrhosis is where you've lost your normal hepatic architecture. You're starting to see such disruption to the normal hepatic globules and such large tracts of scar tissue that the liver no longer looks like a normal liver. And that's a really important diagnosis to make, especially when we're considering treating hepatitis C, because even after cure of hepatitis C, we will need to follow these people indefinitely. It's also somewhat important because it may change the length of treatment. It may also, in some cases, change our choice of treatment. Basically, the message we want to give is that if you're suspicious of cirrhosis, or if you diagnose cirrhosis, we still want these patients to be referred to liver specialists to treat their hepatitis C and manage their cirrhosis. Now, there may be situations, and I noticed in the initial poll question that there are a lot of people from regional centres. There may be situations where it's just impossible to get access to a liver disease specialist, or your patient may absolutely flat out refuse to go to a gastroenterologist because of stigma or bad experiences in the past, or cost, or whatever. And we do still prefer that these people are treated for hepatitis C. Sometimes this is done in conjunction with a liver specialist by telephone or email or through some other communication channel. Personally, as a gastroenterologist, I would much rather these people still received treatment for their hepatitis C, but we would prefer to see them in specialist care if possible. I mentioned there the long-term follow-up after cure, which includes surveillance for hepatocellular carcinoma or HCC. At the moment, cirrhotic status is still required, along with genotype, for PBS approval, and that is unlikely to change. Genotype may disappear, but serotic status is still going to be required. So how I mentioned clinical history taking an examination as a preliminary way of assessing liver fibrosis, and by that I was alluding to the fact that pre-test probability, if you like, is a really important parameter when considering someone's likelihood of cirrhosis. For instance, if you saw someone who'd had hepatitis C for 40 years, had drunk hazardous amounts of alcohol for a similar length of time, was covered in spider nevi, starting to look a little bit jaundiced, and yet your FibroScan came back as a non-cirrhotic FibroScan of, let's say, around 8, I would still be suspicious that this person had cirrhosis. And that's because your pre-test probability is so valuable. If you look at it from the other end of the spectrum, if you saw a young woman who'd had hepatitis C for 1 year, had a little bit of inflammation with a raised ALT, but didn't drink alcohol, was slim and otherwise fit and healthy, and a FibroScan came back with a cirrhotic reading, I would disbelieve the FibroScan and be guided by your physical examination and your clinical suspicion. So I guess what I'm trying to illustrate here is that no one test is accurate enough to overturn all the rest of your data. So we really need to look at all of these things together. So your history, your examination, your laboratory tests, and using the laboratory tests, we can perform a simple calculation called the RPRE score, which we'll go on to in the next slide. And RPRE stands for AST to platelet ratio index. It's basically looking at the degree of inflammation measured by AST. And note that it's AST because a lot of laboratories won't test that unless you request it specifically. So AST compared to the normal range for AST divided by your platelets. Conveniently, less than 1 makes cirrhosis incredibly unlikely. More than 1 can't rule out cirrhosis, so we need to go on to some sort of further test, which may be FibroScan. Now, I'm not sure whether everyone in all of the attendees will have access to FibroScan. You've probably heard of it, and it's probably hiding in an ivory tower in your nearest tertiary referral centre. There are some in the community, or an increasing number in the community. They do often visit from tertiary centres. There are a lot of mobile scans in the community. A lot of private radiology centres have started to introduce shear-wave elastography. It's similar to FibroScan. The cutoffs are all a little bit different. There are caveats involved, but it's probably measuring the same thing, and it's probably going to turn out to be reasonably reliable. Ultrasound is very useful if it shows cirrhosis, and we'll go on to that with one of the polling questions, but it's not particularly sensitive for cirrhosis. In some settings, its sensitivity is only around 50%, so no better than a coin toss. But if it does actually show cirrhosis with nodular liver edge, signs of portal hypertension, then that's a useful diagnosis to have made on ultrasound. So the RPRE, if you don't have access to RPRE on your smartphone, there is an RPRE calculator at this website here. But I'll show you on the next page what an RPRE calculation looks like. I mentioned AST divided by the upper limit of normal, which depending on the laboratory is somewhere between 35 and 45, divided by the platelet count. So you can see that if your AST is very high, say 200, and your platelet count is getting low, you'll end up with an RPRE more than 1. Whereas if your platelet count is preserved, say with Tim's it was 270, and his AST from memory was around 40 something, it'll come out as less than 1. In fact, let's see if we've got it. Here it is. So 46 divided by 40, all divided by 270, multiplied by 100, gives us an RPRE score of 0.4. So we can be very confident that Tim does not have cirrhosis and does not really need any further assessment for cirrhosis. He does not need an ultrasound. This may be different again if Tim had been someone with a long history of heavy alcohol, covered in spider nevi, and a 40-year history of hepatitis C. You may look at the RPRE and still be a bit suspicious and go on and do something else. That's coming back to that point I made earlier, that no single test is completely reliable, but in Tim, this is a pretty good way to exclude cirrhosis. FibroScan, if you have it available, is a measure of liver stiffness. You can see here that it looks like an ultrasound probe. On the end of that probe, it's got a little protrusion that flicks. The patient actually feels a little flick. It's not painful. It feels like flicking yourself with your middle finger. You can see on the screen there's an elastogram that gives us a measure of the speed that the ultrasound waves travels through the liver. A stiff liver will transmit that little vibration very quickly. You'll get a high liver stiffness measurement and you'll diagnose with reasonable confidence the presence of cirrhosis. A normal elastic liver is a bit more like a bowl of jelly. You can imagine flicking a bowl of jelly. The vibration travels fairly slowly through the bowl of jelly and you'll get a low liver stiffness measurement. So it's pretty good at the ends of the spectrum. It's not so useful in the middle, like many tests in medicine. So polling question 3, which of the following findings is least suggestive of cirrhosis? So an RPRE score of 1.9, a FibroScan showing a median liver stiffness measurement of 15, which is high, an ultrasound showing coarse echogenicity, an examination showing a big spleen, ascites and spider nevi, or a platelet count of around 100, a prolonged INR and a low albumin. So which of the following is least suggestive of cirrhosis? So most of them will be suggestive, one of them less so. Very good. So we've got about 2/3 have voted now, and it looks like most of you, almost half, have got the correct answer, which is that an ultrasound showing coarse echogenicity, as you know, it's an incredibly common report, and it's more likely to reflect fat in the liver, either from alcohol or from non-alcoholic fatty liver disease, say in the setting of obesity or diabetes. Platelet count of 100 with a slightly prolonged INR and a low albumin, I would be pretty suspicious of cirrhosis, because otherwise you're having to hypothesize 2 or 3 separate conditions. FibroScan showing a liver stiffness of 15, you're right in that some people with that measure may not have cirrhosis, but it is still pretty suggestive unless there's a lot of inflammation going on or unless the person is significantly overweight. So a slightly tricky question, but most of you got it right. There may have been another poll. I'll just go back a sec, hold on. Oh yeah, so just another FibroScan question. So how would you interpret a FibroScan result of 8? So you probably can't remember the colourful slide I showed a couple of slides ago, but cirrhosis is anything above 12.5, where we get measurements up to 75 before the machine caps out, and normal is anything less than 7, or strongly suggestive of the absence of cirrhosis is less than 7. Normal is actually probably between sort of 3.5 and 5, and a result of 8. Look, it's a bit tricky without me showing you the original slide, and we've got about 2/3 of you voting, so we might leave it there. Look, about half have said moderate fibrosis, which was correct. Half of you have said none or mild. So actually, I'm going to go back and show you the slide because I've had a sudden doubt. No, so there you go. So between 7 and 9.5 is actually moderate. So less than 7 is absent or mild, but it was pretty tricky because we put it right near the cutoff. So those of you who said moderate, look, we didn't even say it on the graphic. So we've said significant, which is a synonym for moderate. So very tricky question. I'm not responsible. Apologies. Let's go on to that sort of summary slide of assessing liver disease. So as I said earlier, no single tool is accurate enough. You need to include your clinical history, your clinical examination as your sort of pre-test probability. An AST to ALT ratio, where the AST is progressively climbing relative to the ALT, that may be strongly suggestive of advanced disease. Although, if someone's drinking heavily, that can also elevate the AST preferentially. I mentioned earlier the low platelet count, even the low normal platelet count, platelets approaching sort of 160, 170 may be meaningful. APRI over 2 certainly suggests cirrhosis. APRI between 1 and 2 raises the possibility. FibroScan above 9.5 suggests severe or advanced fibrosis. Above 12.5 suggests cirrhosis. And if you're seeing signs of cirrhosis or portal hypertension on ultrasound, that's meaningful. If you don't see them, it doesn't necessarily exclude cirrhosis. So splenomegaly, enlarging portal vein, or a nodular liver edge we haven't mentioned there. Especially ascites is a more obvious one. If you're seeing ascites on ultrasound, that would also strongly suggest cirrhosis. So alcohol use is important. So as you all know, alcohol use is incredibly common in Australia. Our safe alcohol guidelines are being reduced almost every time you look. The WHO recently came out and said that there's possibly no safe level of alcohol. And I have recently come across signage in California, which is maybe a bit more litigious than Australia, where they say in every bar and restaurant that no amount of alcohol is safe, and if you're pregnant, it might harm your baby. So I think there's probably still lessons to be learned with alcohol. In terms of treating hepatitis C, drinking alcohol is not going to impact on our chance of curing someone's hepatitis C, but hazardous intake may go on to cause significant liver disease even if we cure their hepatitis C. I try not to be sort of too dogmatic about alcohol, particularly in the first consultation. I don't want to put the patients off and lead to them never coming back. I might introduce it later on as an important concept, particularly if I'm worried that they're at risk of ongoing liver disease. But it's certainly not a reason not to treat hepatitis C. So what do we know about Tim so far? We think he was infected back in the 80s from his brief period of injecting drug use. We haven't yet seen his genotype or viral load, although, as I said earlier, his viral load's not particularly relevant. We're confident he doesn't have cirrhosis with a low APRI score. He doesn't drink. He's got no other known comorbidities. He's not co-infected with hepatitis B or HIV. He's on no other medications, which is important. He's never been treated for hepatitis C before, and we're not worried about doing surveillance for hepatocellular carcinoma. What else would we like to know? So here's the genotype, genotype 1A. So I mentioned in that first slide that genotype 1 is the most common genotype in Australia at around 50%. I forgot to notice that subtype. We should take it out because it's no longer relevant. The laboratories will still report subtypes. They'll tell you 3A, 3B, 1A, 1B, but it's no longer at all relevant. In the old days of interferon and some of the early DAA regimens, it had some relevance. So we're still required to report that genotype to the PBS when we call up the 1-800-888-333 number. And we're still required to tell them that he's non-cirrhotic. So what else should we do? Should we treat him? Well, the answer is obvious. We should all treat Tim or anyone like him, particularly if he's interested in treatment. So in terms of other things we might like to know about Tim, I mean, Tim is deliberately fairly straightforward, but I should point out that a lot of the people who are coming forward with a new diagnosis of hepatitis C are much less straightforward than Tim, and much less straightforward than the people we treated over the first 3 years. So they will often have slightly different ideas about health in general or liver health specifically. They'll often have different ideas about hepatitis C. They may be people who've experienced severe stigma and discrimination through their lives. I mean, that could apply to anyone who's had a diagnosis of hepatitis C, but personal experience and other conversations with peers is that people presenting now have often had extreme discrimination and stigma, and that's why they haven't come forward in the first 2 years of DAA therapy being available. They may be concerned that because they're still drinking or still injecting drugs, that they may not be suitable for treatment with hepatitis C, but we need to reinforce safe injecting behaviours and safe drinking behaviours, but we shouldn't let ongoing injecting or heavy drinking be a reason not to treat someone, and we need to make that clear to people. We should offer needle and syringe programs if they are not already accessing these. We should think about opiate substitution therapy if they're not already accessing OST. We should also vaccinate for A and B if they're not immune. And we'll talk a bit more about other concomitant medications in a moment. So I sort of touched on stigma and discrimination. I'm not going to show you this video, which is a very good video, but goes for about 5 minutes. But you can see the link there, and you should be able to access it at a later date. Even if you just put into Google ASHM, hepatitis C, stigma and discrimination, I'm sure this will come up on Vimeo. But I am yet to meet someone with hepatitis C who hasn't experienced stigma and discrimination, particularly those people who were diagnosed, like many of our patients who were diagnosed in the 80s. Many of them were told that their virus was incurable, they were going to die, and basically go away, don't drink, and we're sorry, there's nothing we can do. And they will have all known someone who's died from hepatitis C. So they may come bearing a lot of baggage related to the diagnosis of chronic hepatitis C, and that's just something to be aware of. We're trying to turn stigma and discrimination on its head and to give hepatitis C a positive stigma, in that hepatitis C is the only curable virus. It's also one of the few curable chronic diseases. So if you had to get a bloodborne virus in 2019, well, hepatitis C is a pretty good diagnosis to get because it's curable with a short course of medications which don't cost much money. So you might like to just think about ways that you could reduce stigma and discrimination in your practice. I mean, I think about in our tertiary practices, even the naming of a clinic, a hepatitis clinic, I think comes with a bit of stigma, and we've tried to remove that wherever we can. I mentioned earlier that hepatitis C transmission and reinfection remains an issue. It shouldn't be an issue that we use to lead us not to treat hepatitis C. I've often heard my colleagues, particularly Greg Dorr, say that if we're not seeing hepatitis C reinfection, well, we're treating the wrong people. The idea behind that statement is that in order to have a big impact on the hepatitis C epidemic, we need to be treating people who are still injecting drugs, and they're the people who will be at risk of reinfection. So what we have been gratified in seeing is that reinfection rates are very low, but we shouldn't be put off by the risk of reinfection, because that actually tells us that we're treating the right people. What it does tell us, though, is that we need to do more than just treat chronic hepatitis C. We need to remind people of safe injecting practices, so that's not just clean needles and syringes, but also clean other injecting equipment. We need to be treating people's social injecting networks. Now, that's very tricky. I understand that networks of people who inject are often just that. They're networks of people who inject, and these people may share nothing else other than the act of injection. They may not be friends, they may know nothing else about each other, they may just get together infrequently or frequently to inject. So it's often very hard when you're seeing someone who's still injecting and you're suggesting that all of their injecting partners should be treated. It's often hard to turn that into sort of practical action. And I guess the message is just that we should be treating as many people with hepatitis C as we can. So I mentioned earlier that the risk of reinfection was low in many of the studies of people with hepatitis C alone. That reinfection risk was less than 1%. In studies of people at high risk of reinfection, so that's people injecting drugs or people in prisons where they don't have access to clean injecting equipment, but where we know that injecting still goes on at a similar rate, the risk of reinfection is much higher. In some of the studies of men with HIV and hepatitis C co-infection, that rate is even higher. And I guess that tells us that changing sexual practices is often more difficult than leading to changes in injecting practices. So let's talk about initiating treatment for TIM. So we've got another polling question here. So I think we've already answered this, but would you recommend hepatitis C treatment for patients with chronic hepatitis C who are on opiate agonist therapy or opiate substitution therapy, or who are currently injecting drugs? I mean, in the old days of interferon, there was a time where we were reluctant to treat people who were still injecting. That changed towards the end of pegylated interferon's lifetime. I think there are still people who hold the view that we shouldn't be treating people who are at risk of reinfection, but as you've all, or pretty much all, correctly assessed, people who are on opiate substitution or are still injecting at risk of reinfection should definitely be offered treatment with direct-acting antivirals, DAAs. So the main message is that anyone with hepatitis C with a positive PCR is eligible for treatment. The one caveat, I guess, is people who are expected to die from some other condition within the next few months. So whether that's 6 months or 12 months, you could argue that if someone's facing imminent death from some other incurable condition, that treating their hepatitis C is probably not going to make that much difference to their quality of life and therefore probably not worthwhile. But they're about the only people who we should not consider treating for hepatitis C. So there are huge benefits. We've talked about the benefits to the population, where we can reduce the risk of transmission from people who are still injecting drugs, and this goes to the WHO elimination goals, which we haven't really sort of talked about, but hepatitis C is one of those conditions where we should be able to eliminate it as being the currently significant public health problem that it is. Whether we'll actually be able to eradicate it like smallpox or polio in some areas is a bit more debatable, but we should be able to eliminate it as a public health problem. The benefits to the individual: well, it reduces liver disease progression, so prevents cirrhosis. Even in people with cirrhosis, it can lead to cirrhosis regression, reduce their risk of decompensation. Prevention of cirrhosis can certainly reduce the risk of hepatocellular carcinoma, HCC. We don't really sort of talk about the risk of hepatitis C and HCC, but curing someone's hepatitis C can reduce all of the risks of chronic liver disease, including HCC. Doesn't mean that you don't need to keep doing surveillance in someone with cirrhosis, but it certainly does reduce the risk. So treatment, as I alluded to, is incredibly easy and effective. So let's talk a little bit more about treatment. So all of the treatments are all oral. There are very few side effects, which we'll go into in some detail. All of the treatment courses are incredibly short, and for all of the patients you're going to be treating, treatment is either 8 or 12 weeks. There's basically no monitoring while they're on treatment. We do some monitoring, which we'll talk about, at the end of treatment and 3 months after treatment, but there's really no monitoring while they're on treatment other than checking that they're picking up their prescriptions and have no complaints. The cure rates are over 95% in most groups. And in the vast majority of people, we really do see a tangible improvement in their quality of life. whether that's the disappearance of their fatigue, nausea, their mood disturbance such as depression and anxiety, or more subtle improvements such as improved sleep quality and just improved energy levels. In most people, we see some sort of tangible improvement, and that's why, again, treatment should be offered to everyone with chronic hepatitis C. So what can Tim expect to experience? Well, we would hope that Tim will experience an improvement in his fatigue. I think that was his presenting complaint. So let's talk about the details of what is actually available on the PBS. If you've got a bit of spare time and are sitting at a computer with access to the PBS, it's worth just clicking on one of these medications. So, for example, sofosbuvir, bringing it up in the search field of the PBS, clicking through the authority link and going to the table that we still have in terms of which medications are useful for which genotypes. The reason it's worth doing is it's still a complete, a very confusing mess. So what we've tried to do in these slides is make it much simpler. And I think if you're new to the treatment of hepatitis C, you could make a pragmatic decision to just learn about 2 medications. You could just learn about those 2 medications which are pan-genotypic. That is Epclusa, which is sofosbuvir valpattosvir, a 1 pill once a day for 12 weeks. The other pan-genotypic regimen is glecaprevir pibrentasvir or Mavorite. It's 3 tablets once a day with food for 8 weeks. There are some genotype-specific medications, which are fantastic medications, again, side effect free, again, incredibly high rates of cure, and very useful. But as you see here, sofosbuvir, ledipasvir or Harvoni is only indicated for people with genotype 1. And for Zepotir, crizoprevir, elbasvir is only indicated for genotypes 1 and 4. So if you were new to the space and found it difficult to delve into all the details regarding genotype, it would be reasonable and pragmatic to just focus on these 2 pan-genotypic regimens. But we include these because they are great medications and they may be the best option for your patient depending on drug-drug interactions or something else that's going on in their life. So definitely worth knowing about if you have capacity. There is also another regimen that you will see down here, sofosbuvir decladisvir. That's 2 separate tablets. It's on the PBS for genotype 1 and genotype 3. For some patients, depending on their drug-drug interactions, particularly for those people with HIV, that may actually turn out to be your best choice. But back to keeping it simple, pan-genotypic regimens, sofosbuvir valpattosvir here, 1 pill once a day for 12 weeks, with or without food, or the glecaprevir pibrentasvir Mavorite, 3 tablets once a day for 8 weeks with food. Now you can see there that people with cirrhosis for Mavorite need 12 weeks, but remember, we're not suggesting that you start treating people with cirrhosis. So that's why that table is there for interest value only. For people without cirrhosis, we are just looking at 8 weeks of Mavorite or 12 weeks of Epclusa. Harvoni there is 8 or 12 weeks. I'll show you in the next slide why 8 weeks is still an option for some people. And the Zepotir, crizoprevir, elbasvir there, 12 weeks, 1 pill once a day. Decladisvir, sofosbuvir, again, the 2 separate pills for just 12 weeks. This one down here is not on the PBS. It's a triple regimen with 1 pill, and it's going to be probably reserved for just salvage therapy, so people who've failed previous therapies. Probably should make this point that for all of the people we're intending GPs to treat, we want to actually limit it to people who haven't been treated with DAAs before. If someone's had a DAA regimen and it's failed, we should probably see those in specialist centres because it may be more complicated. If someone's been infected with hepatitis C, treated, say, with Harvoni here 3 years ago in 2016, cured, and then gets reinfected with hepatitis C, that's not a treatment failure, that's actually a reinfection. So we're happy for you, GPs, to treat reinfections. But if someone has had a previous treatment and it didn't work, and you're suspicious of treatment failure, that's someone where we actually want to see the patient in a specialist centre, because that could be a bit complicated. But for these people, we're talking about naive to treatment with no cirrhosis. So it's difficult to separate Mavorite over here, glecaprevir, probentasvir, from Epclusa, sofosbuvir, velpatasvir. And we've made it even more difficult by flipping the sides. I think the slide earlier showed Epclusa over here and Mavorite over here. So it is very difficult to differentiate. It may come down to just personal choice. Someone may be really keen for 8 weeks treatment. Someone over here may only want to swallow 1 pill a day instead of 3 pills once a day. But the main differentiation may be in their concomitant medications. Epclusa can't be used in people with severe renal impairment, but we're not imagining that you're going to see many people with severe renal impairment where you're going to be treating the hepatitis C. The similarities are that they're both pangenotypic. Adverse reactions are mild, headache and fatigue, and I think we show on an upcoming slide some of the other, there we go, there are the adverse effects. So all very similar. It's really 4 things: headache, fatigue, nausea, and diarrhea. And it should be said that these side effects or adverse effects are listed, but in all of the clinical trials, the rates were pretty similar to placebo, particularly in many of the Zepatier trials, where the rates were numerically almost identical to placebo. And in some arms, the placebo rates of these side effects were actually numerically higher, although it didn't reach statistical significance. So you can confidently say to patients who ask about the side effects of these treatments that they're incredibly well tolerated and that the side effects are incredibly mild. In all of the studies, the side effects leading to discontinuation was less than or around 1%, so incredibly low. And a lot of people will be bringing their baggage of previous treatments with interferon to the consultation. So I've sort of gone over those details before. All genotypes for Epclusa and Mavorite, genotype 1 for Harvoni, genotypes 1 and 4 for Zepatier, and 12 weeks for all of them. So what are our options for Tim? He had genotype 1, remember, so you can't go wrong. You can pick any of the medications on the PBS, and Tim has a 99% chance of cure. So what would you prescribe? Well, it doesn't really matter. You could give him anything, like I said. But your 8-week regimens would include Harvoni because he had a low viral load, or Mavorite for 8 weeks. I mentioned drug-drug interactions. It's probably not worth going into great details, the drug-drug interactions, except to say that they are sometimes very important and that there's a fantastic online resource. You may like to access it on your smartphone, or you may prefer the laptop or desktop version. I prefer the desktop version because I can put in all the patient's concomitant medications, put in the suggested hepatitis C treatment. If there's a drug-drug interaction that is incompatible, the website will actually come up with an alternative, which is fantastic. And then I can print out the PDF, put it in the patient's file, give a copy to the patient, and the patient can even have access to the website and check any new medications that might come along. It's worth mentioning proton pump inhibitors, which reduce the absorption of some medications. Statins sometimes are important, and the dose may need to be reduced, or the statin may need to be switched. There are no safe hepatitis C treatments with Tegretol. Tegretol carbamazepine changes your liver function, changes the enzymes, and makes most of the hepatitis C medications disappear to such low levels that the treatment wouldn't work. Ethanol estradiol containing medications are important with Mavorite and shouldn't be used. St. John's wort can have a similar effect to Tegretol. And it's worth asking, what else is the patient taking? They're often taking over-the-counter things that they may not remember or describe as medications. Nothing was relevant for Tim because he had no concomitant medications. So missed doses. I must say that with these new regimens, they are fairly forgiving, and 1 or 2 missed doses are not going to make a big difference. If someone's missing weeks at a time, that will make a big difference. Our advice is obviously to try and sort of optimize adherence and to ask a patient to continue the treatment until it's finished. If you're really worried about someone's adherence, you may like to get them into your clinic more frequently just to check how many doses they've missed. Some people may even like to have the treatments be dispensed with their opiate agonist therapy, or by the pharmacy, or by the clinic nurse. There may be lots of sort of novel ways of approaching difficult adherence. But remember that the regimens are relatively forgiving, and as long as the person completes the course, they should have a very high chance of cure. Pill boxes, dosette boxes, mobile phone alarms involving a significant other. There may all be other ways of optimizing adherence. You'll notice on the PBS that treatment can be prescribed by any person experienced in the treatment of hepatitis C. Now, the number of patients needed to treat before you consider yourself experienced is not defined. It's really a level of comfort. Some people may feel confident with these, particularly with the pangenotypic regimens, to feel experienced after just 2 or 3 prescriptions, and that's perfectly reasonable. Others may want a few more. You may treat 10 people and then come across something that you're not familiar with and seek further guidance. So there are several ways of getting that further guidance. There are some remote consultation request forms that can be downloaded from GSA or from ASHM or hepcguidelines.org. Or you may have a preferred specialist in your network or in your orbit who you are happy to contact. Personally, I have my own sort of form, or I'm happy for text messages, emails, phone calls. It doesn't really matter. There are many ways to give the appropriate advice and to sort of help you improve your level of confidence and share really the joy of treating people for hepatitis C, because even though we talk about all of the ins and outs and the detail, it is almost always incredibly rewarding and incredibly successful. So who would we still prefer be referred for specialist care? Well, those people with cirrhosis, or where there's a suspicion of maybe early cirrhosis or advanced fibrosis. We didn't talk about extrahepatic manifestations. Basically there we're talking about people, say, with arthritis due to hepatitis C, or a lupus-like syndrome, or say renal disease related to hepatitis C. We would still like to see them, basically because they're uncommon and very interesting. Complex comorbidities, so someone with, say, severe cardiac disease, severe renal disease, HIV or hepatitis B dual infection. I mentioned earlier someone who's failed their first attempt at DAAs, so treatment failure, no longer naive to therapy. We would prefer to see them in specialist care because their second treatment may be difficult. People with acute hepatitis C, remember the PBS is just for chronic hepatitis C, so someone with acute hepatitis C isn't actually eligible under the PBS. We would find ways to consider treating their acute hepatitis C, and that may actually be in a clinical study. Many of the tertiary centres and clinics around the country have access to clinical trials of acute hepatitis C where we're exploring shorter durations of currently available therapies. So monitoring and follow-up. So we mentioned the things to do at baseline. We've put there a viral load, although, as I said earlier, that is really an option rather than necessary. We've put in light grey LFTs on week 8 of Zapatir. It's in the product information. It's something that we should do. It's something that's often not done with no particular consequence, I must say. I said in some people we would test at the end of treatment. I would only do that if I was really worried about adherence, or in someone with decompensated cirrhosis. For the vast majority of people, actually the only blood test they need is a test 3 months after they finish treatment, so post-treatment week 12, where we're testing for cure. We're doing a hepatitis C PCR for RNA, a yes or no test, a qualitative test. We're also doing some liver function to see if that's returned to normal, if it was abnormal at baseline. And we denote this cure of hepatitis C or sustained virological response 12 weeks after treatment. So as you know, everything in medicine has a convoluted acronym, and this is the convoluted acronym in hepatitis C, the SVR12. We've mentioned there in the fine print ribavirin. We're really not talking about treating people with ribavirin anymore, except in sort of complicated retreatment scenarios. And I mentioned people with cirrhosis who might need closer attention. So we chose to give Tim just 8 weeks of sofosbuvir ledipasvir or Harvoni. He was busy working, so he didn't come in at week 4. We just telephoned him. He was doing well. Slight headache, which may have had nothing to do with his Harvoni. He'd taken we thought about some Panadol and didn't take it. He hadn't missed any doses, which is great. And then we did a blood test 12 weeks after he finished treatment. His liver tests were normal, and his Hep C RNA was negative by PCR. So he achieved the SVR12. So is he cured? And does he need any further follow-up? 10 years ago, we were sort of hesitant to use the word cure. We now have no hesitation in saying that Tim is cured of chronic hepatitis C. He doesn't have to tell anyone he's got hepatitis C. He does not have hepatitis C anymore. It's in his past history column. He's cured of hepatitis C. Does he need any further follow-up? Well, he's not at risk of reinfection because his last exposure was almost 40 years ago, and he doesn't have cirrhosis. So as uncomfortable as it feels for a chronic medical condition, he actually doesn't need any further follow-up. The door's always open for some future problem to represent, but we should be telling people like Tim that he's cured of hepatitis C. He doesn't need to keep testing for it. He doesn't need to worry about it. He doesn't need to tell anyone about it. The only thing he couldn't do really is donate blood or join the army. Remember that hepatitis C antibody tests remain positive after cure. That will remain positive indefinitely, so 10 years, 20 years, a lifetime, and should not be repeated. We often see that it is repeated. Say Tim moves workplaces again and goes to a new GP. He may mention the hepatitis C, and the new GP may do an antibody test. Tim may have forgotten about this treatment in 10 years' time because it was so innocuous, and the positive antibody may sort of trigger his memory of this treatment. Treatment failure. So if you treat 100 patients, one of them will experience a treatment failure. That's where there's still virus detectable by PCR 12 weeks after treatment completion. So that's where we would like to see them in a tertiary centre, because that's a treatment failure, and the second treatment is going to be a little bit more complicated, which again is the topic of another webinar. Do we have one more polling question?
We do.
There we go. So your patient, Tim, achieves SVR12, has no cirrhosis, but is at risk of reinfection. So sorry, not Tim. What post-treatment follow-up would you put in place? So monthly antibody, an annual PCR, 6 monthly antibody and PCR, or an annual antibody. Okay, so to be distinguished from the monthly antibody. So we just said earlier that the antibody is going to stay positive for decades. I think I've seen maybe 3 antibody clearances in my almost 20-year career, so it's pretty infrequent. And most of you have answered, so that's good. And most of you have said correctly the hepatitis C PCR. So in someone at risk of reinfection, Medicare will let us do a hepatitis C PCR once a year to look for reinfection. Now, if 6 months later the LFTs are abnormal again, that would be the time to do it, rather than to wait another 6 months so that a year has elapsed. And what you would write in your clinical notes on the request slip is just query acute hepatitis C reinfection, and the laboratory could then do the PCR under Medicare. So who needs follow-up? People without cirrhosis don't need follow-up. People without risk of reinfection don't need follow-up. Men having sex with men or men with HIV or people injecting drugs should have ongoing annual PCRs. Now, if the liver tests don't completely return to normal, then we may need to think of other causes for abnormal LFTs, and that's where you should think about referring them to a gastroenterologist. Now, that may be something as simple as fatty liver disease, which, as you all probably know, affects about a third of adults, but it's worth thinking about other causes, including autoimmune conditions or hemochromatosis or other bloodborne viruses if the testing for that wasn't performed, and it's worth considering referral. But TIM, as we said, does not need any further follow-up. I don't think it's actually worth going into great detail about what happens to people with cirrhosis, because remember, they're the ones that you're referring to specialist care anyway. So this gives us something to do because we're, from specialist care, we're seeking the help of all GPs in the country and giving away all of the easy people without cirrhosis to treat. So you've got to leave us something to do in the specialist care ivory tower. So we are performing surveillance for hepatocellular carcinoma with 6-monthly ultrasounds. We're vaccinating for other infections. We're looking for decompensation, and we're doing screening and surveillance for varices and osteoporosis. So that will keep us busy for decades to come. And I mentioned surveillance for HCC. Basically, we're doing ultrasounds and we're doing alpha fetoproteins, with the caveats that it's not a very good test. So other special issues you may need to think about. So people with prior treatment I mentioned. Pregnant women, we can't at the moment recommend treatment with DAAs. If they're pregnant, we would wait until delivery. Treatment failure, we want to see them in specialist care. I mentioned the general statement for the drugs of treatment of hepatitis C via the PBS website that you follow. Put in, say, one of the drugs into the search, like sofosbuvir, follow the clicks, and you'll end up at the general statement. Or you can go to the consensus statement, which was put together by GSA, ACID, and Hepatitis Australia, ASHM, and others, and the ALA. So I think this is our last polling question, and then we've got 10 minutes for your questions. So Gemma is wanting to have a child. She's got medium fibrosis or moderate fibrosis, genotype 1. What would you suggest? Start treatment now, and she can wait 6 months after treatment before conceiving. Start treatment now and wait a month. Conceive now, there's only a 1 to 2% chance of transmitting to her baby, or conceive now, start treatment after delivery because there's no risk in breastfeeding. So this is a little bit complicated, and just so that you've got plenty of time to ask your other questions, I might just close the poll early. It's a tricky one because I didn't really sort of tell you much of the answers. Those of you who've said 6 months, that you need to wait 6 months after treatment, that was true for interferon and ribavirin. But in fact, with these drugs, we think you only need to wait for a month. So look, you could argue the toss on those, but we would only suggest waiting a month, and then Gemma should be able to conceive. That 1 to 2% risk of transmission is a little low. I mentioned earlier it was 3 to 5%. We don't know much about any of these medications in breastfeeding women. So the advice on all of the product information, in all of the product information, is that only do it if risk outweighs benefit. Sorry, benefit outweighs risk. All right, I think that might be one more. Okay. Oh yes. So when are DAAs contraindicated? Well, in pregnancy, we still, the category B, which is not A, I guess, but they're still contraindicated in pregnancy. We don't use ribavirin anymore. Ribavirin was teratogenic category X. We'd suggest avoiding during lactation. We recommend contraception during pregnancy, and we suggest waiting for 4 weeks, like I said. I've mentioned treatment failure. It's very uncommon, 1%, and we want to treat those people in specialist care. I mentioned earlier that reinfection is not a treatment failure, and we're quite happy for GPs to treat reinfection. You treat that new infection as if it were a first infection, and you may even need to use the same regimen again. as long as you're confident that it's a reinfection. And you would be confident it were a reinfection if they'd had that negative test 12 weeks after treatment finished, that SVR12 time point. So I think we've got there. Yeah. So I might. I mean, you can see the websites there for further learning, but I might go back to Amy. And Amy, have you had any questions from our attendees that you thought we hadn't addressed during
Yes,
this?
absolutely, and thank you very much for that presentation, David. There were quite a few people asking about vaccinating against hepatitis A and hepatitis B for people who are either Hep C positive or about to start or undergoing treatment, and what were your thoughts there?
Look, a very good question. There should be no interaction between the vaccine and hepatitis C treatment. So I wouldn't wait. I would do the two together. I wouldn't wait for vaccination before you treat, and I wouldn't wait for treatment before you vaccinate. So, I mean, many of our attendees may be in areas where there's been a recent hepatitis A outbreak. And so there have been programs to sort of catch up or treat people who might be at risk of hepatitis A with the vaccine. Hepatitis B vaccine should be available free to anyone with hepatitis C. There are various reasons for hepatitis B vaccination to be available free on the PBS, and having hepatitis C, I don't know if it's specified, but there's a sort of a broad indication, which is anyone at risk of hepatitis B. And so you could argue that having hepatitis C means that getting hepatitis B puts you at greater risk, or you might have hepatitis C because you've been injecting drugs and therefore are at greater risk of hepatitis B. So it's one of those indications for the free access to the vaccine. So hepatitis B is 3 vaccines over 6 months at 0, 1 and 6 months, and then you do a blood test to check surface antibody levels 1 month after that third injection. Hepatitis A vaccine can be done as a twin-rix vaccine with the Hep B, or it can be done separately, just as one vaccine, which gives you a year or two's immunity, or 2 vaccines a year apart, which gives you 10 years immunity.
Excellent. And just one final question. Again, we had quite a lot of interest in the beginning relating to transmission through sex, whether it is in fact a sexually transmitted infection or what types of, I guess, sex causes transmission of hepatitis C.
Very good question. So we, over the last 30 odd years, have said, no, that's too long, 28 years, have said that hepatitis C was not a sexually transmitted infection. And the reason for that was that transmission in heterosexual couples, stable heterosexual couples, was incredibly uncommon at around 1%. That message that it's not a sexually transmitted infection needs some caveats, and those caveats are people with multiple sexual partners, people at risk of other sexually transmitted infections, particularly syphilis. We see a lot of co-transmission of syphilis and hepatitis C. We also see a lot of sexual transmission of hepatitis C in men having sex with men. And the reasons for that are complex, but it probably reflects more risk of mucosal breach. So normal vaginal mucosa without a tear and without bleeding should be relatively resistant to hepatitis C, and that's reflected in the lack of transmission in heterosexual couples. But other mucosa, such as anal mucosa, rectal mucosa, or the use of drugs while having sex or multiple sexual partners while having sex, they may mean that hepatitis C is sexually transmitted. So that's where that sort of broad statement needs some nuance and needs some detail. And look, there may be attendees who are highly experienced in the area of sexual transmitted infections who are much better at taking a sexual history than I am. But I think just broadly, it's not transmitted between stable heterosexual couples, but it is transmitted in more higher risk situations would be a reasonable summary.
Excellent. Well, thank you very much, David. I think we'll stop there. There were lots of questions. You actually managed to answer a lot of them during the course of the presentation, but there is the potential that we might collate some of those questions and send out some answers later in the email. Just a reminder to participants, you will receive a post-event email, and you need to complete the survey to get your CPD points, and you can add your RACGP number there if you haven't already. There was a question about whether the slides would be available. We will need to confirm that with Asham, but if we can send them to you, that will be included in that post-event email. So I'd like to again thank you, Dr. David Iser, for what a fantastic and informative presentation.
Thanks, Amy.